Thank you, and welcome everybody back from that quick break. It is now my pleasure to introduce our co-presenters who are here from the New York State Office for Aging that are going to talk with you about the Office for Aging and AAA resources. So their slides are already up. Thank you for doing that. I'm going to just tell you a little bit about who we have with us today. So we have Greg Olsen. He is the Acting Director of the New York State Office for Aging, or NYSOFA. In this role, he is responsible for the development, implementation, and administration of programs and policies that help older New Yorkers and overseeing the administration of federal and state-funded programs that assist more than 4.6 million older adults and 4+ million informal caregivers across New York State. Greg received his master's degree in social work with a specialty in gerontology from Syracuse University's Maxwell School. He is joined today by Becky Preve. She is the Executive Director for the Association on Aging in New York, a member organization representing the 59 area agencies on aging in New York. The mission of the association is to support and enhance the capacity of New York's local area agencies on aging and to work in collaboration with the Aging Network to promote independence, preserve dignity, and advocate on the behalf of aging New Yorkers and their families. Becky earned her Bachelor's of Science degree from Clarkson University in 2002 and has also received certification from the Institute for Healthcare Improvement and Boston University of Social Work. So thank you both for being with us today. I'm going to go ahead and mute myself and let you take it away.
Well, wonderful. And thank you so much for having us both. As you heard, I'm a trained geriatric social worker. I've been doing this about 33 years. I'm going to first shout out to my good friend, Anne-Marie Cook. I started my career as a case manager, actually working for Lifespan back in 1992, before it was called Lifespan. It was called the Regional Council on Aging. So just shout out to her, as well as we have 4 of our directors that are on today as well. Brenda Wyman from Cayuga, Diana Fox, Orleans, Beth Stranges, Chemung, and Andrea Fettinger from Fulton. I can't help but, say how great this was organized to have Dr. Pogowski talk about some of the solutions that can help older adults, reconnect, combat isolation and loneliness, because a lot of what we're going to talk about today are not the problems, but the solutions. And, the focus here is clearly on rural areas, and we have 59 county offices for the aging. 42 counties are designated statutorily in New York State as rural, but even a place like Albany, where I live, 10 miles away from downtown Albany, is rural as well. So there's a lot of areas of the state that are, and there's an office for aging and many of their partner organizations in every single county. So we are going to shift gears a little bit because we talk about aging differently, and this is particularly relevant and important in rural areas for county managers, county executives, elected officials, and others to really understand who actually lives in the community and who older adults really are. And what I mean by that is we live in an ageist society, and we've been taught through a variety of direct and subconscious messaging through television, cartoons, movies, print media, advertising about anti-aging and the negative part of aging, which is older adults are frail, they cost a lot of money, they don't give back to their communities. In other words, they take more than they give, and that is absolutely false. And we're going to put some data behind that, because this is really important information for leadership, whether it be assembly members, senators, or county elected and others, businesses, et cetera, to understand in order to keep rural communities economically, socially, and intellectually viable. I'm not going to go through, because you guys are much smarter than I am on this, but we know aging starts at birth. It's not some random age, 60, 70, whatever it may be. And so as we're moving through, and I think Anne-Marie talked this morning about the master plan, it's really about birth to death. How can we have a positive impact with children so that they grow into middle age healthier? How can we change behaviors in middle age so that they grow older? And then how can we change the caring economy so that we're serving older adults in the setting that they want to be in at the least intensive and least expensive. And that's not the system that we have. In fact, we do not have a caring system right now. We have a payer-driven system that focuses all its money and attention on the back end, hospitals, ED visits, rehab, nursing home placements at the expense of the community. And that's really what we're trying to balance out. Growing older isn't the problem. It's how we've organized not only the state, but the national caring economy. You guys know as well as I do, how you grow up, your education, financial, social experiences are going to have a huge impact, again, across the lifespan, and certainly as you're older. And aging is not a disease. A lot of people have chronic conditions. Those are diseases, but aging is not a disease. This is, when we're talking about older adults, at least from our perspective, statutorily, it's the 60+ population. You could literally have 3 to 4 generations within that 60 to 105 cohort. So to think that we should be talking about or providing interventions and supports the same way for a 60-year-old or a 75 or 100 is ridiculous. And so we can't be painting the population with one broad brush, but unfortunately, we do that with older adults and no other population. There is enormous variation in health, functional ability, financial status, you know that. And I'm going to spend a little time on the social and economic impact because these are the things where Becky and I, either together or independently, talk to businesses, county managers, anybody that will listen, and you put the data behind it. Nobody talks about aging this way. They talk about it the way that we have grown up to learn, which is from a deficits perspective, not a strengths perspective. And that's what we're trying to change. And I hope that you guys will help us do that as well. All the data that I have today, I have by county, by region, and I'd be happy to share it with you. So let's just take a look at, the 50+ population nationally. This was a result of a meeting that I had with AARP National in New York State on data that we began to collect about 12 years ago. Because in my opinion, the way that I grew up, the older adults that were in my life, the people that I worked with in a variety of organizations did not match what I grew up to believe or what I was told or the, either subconscious or direct messaging that I got. So I started to think about aging from a positive lens, an economic development lens, even though there's a portion of the population that do need assistance. And that's our jobs to provide that. That is not who older people are. And so if we're just looking at the economic impact for the 50+ cohort, they are the highest spenders in all these areas. I'm not going to go through the top 5 bullets, but on the bottom, they're the #1 volunteer group. I'm going to show you that. #1 givers to philanthropy and charity. #1 entrepreneur group. If you are starting a business in your later years, after 3 years, you have a 78% chance that business is still running. You take a younger individual that starts their business, after 3 years, a 20% chance of success. And there's a reason for that. Our life experience, our family experience, and so on, that gives us the tools that we need to be resilient and to do things later in life. And they're an absolute huge tourism block. So I challenge any of you, and I challenge myself also, because I do this all the time. It doesn't matter where I go, from a pharmacy to a campsite, to a big box store, to a local cafe, and you look around and see who's there, a mall, and what you're going to see is an overwhelming number of older adults. But somehow we see them as invisible. And I challenge you guys all again, because I think about this all the time. At what point, take your own life, the things that you've done in work, the things that you've done with your family, the experiences, the relationships that you have, the passions, whatever it may be, that at some age or at some look, society just writes that off. And it's really a shame, but that is exactly what happens based on either an age, but it's usually a look. And we're trying to combat that because it's just simply not true. So take a look at New York State as a whole. The 50+ population, GDP are the goods and services that we produce. 43% of our state's GDP is by the 50+ population, 719 billion. Their spending supports almost 6 million jobs, and you can see the projections from 2050. Many are still working, and we have data to show that individuals, as of today, are not looking to retire until they're in their mid to late 70s, are still contributing $482 billion in wages and salary. The local and state tax base, if you combine it, is about 41%, $72 billion a year. What that means is you do not have a local, county, regional, state, or national economy without the older population. So what's a geriatric social worker talking about this for? Because if we're not telling the truth about who it is we're actually serving and the population as an aggregate, and we can always dive down into subgroups within the population, and we're looking at the population from a devalued lens, you don't put resources into things that you devalue. You do intervene very, very differently on things that you do value. So I'm asking you to help me, to help Becky, to change the narrative, combat ageism, and talk about the value of this population. Let's go a little bit further. This is just the retirement system in New York State. I wish I could get the rest of this, and I'm working on it, but 80% of our retirement system stays in New York State, 10.6 billion. I apologize, the Social Security number has changed. $59 billion recession-proof money is pumped into New York's economy every single year. We have 1 million volunteers providing 500 million hours of service to thousands of not-for-profits in your communities and across the state at an economic value of $13.8 billion. 1 out of every 7 jobs in New York State is a not-for-profit. And these are not just individuals that are serving in our network, in our long-term care ombudsman program, our high cap program, food service, transportation, home delivered meals, but we're talking about every not-profit across the state that would not be able to have the capacity that they do without the voluntary contributions and civic engagement of older people. I'm going to take the 64% and take New York City out of it. 72% of older adults who own their own homes have no mortgage. They're sitting on trillions of dollars of home equity. And I think that we have to find a better way, somewhere between a HECM loan and a home equity loan, to allow individuals on a pay-as-you-go way to use the equity in their homes to stay at home. And we've put a couple proposals out to do just that. And then family, friends, and neighbors that take care of a loved one. We have 4.1 million that are providing service in the tune of $39 billion. I think for decades, the common wisdom was that families, friends, and neighbors provided a wraparound supplement service to the formal system, social services, long-term care, health. That is exactly wrong. It's opposite that. The formal system is the wraparound to what families have been doing for hundreds of years. And so we can't be talking about healthcare, long-term care, social services without including what family, friends, and neighbors do every single day for a loved one, regardless of age. So again, I want to give you a kind of a snapshot of a particular region that's all rural. And again, I have this for you guys if you're interested, not only on a regional basis, but from the county basis. So just take a look at the North Country region. This is pretty consistent across the state, which total population over time is going to grow, but it's only growing in one area, and that's the 60 plus. We're seeing population losses in the 0 to 17, obviously 18 to 44, and many of the 45 to 59s over time obviously are moving into the 60 plus. Now, if you come at this from a deficits perspective, this is where the bad language comes in. Silver tsunami. I hate that. I absolutely hate that. What good has ever come from a tsunami? Death and devastation. But if we can actually take the positives of the older population, who they are, then I think that, again, our interventions can be different. And I'll talk about that in a second when we get to our statewide needs assessment. Here's the economics of the North Country region. I mean, take a look at this. 45% of all the household income, or 64% for the 45 plus. That's a huge portion of the economic base. Now, why does that matter? It matters because New York is still the largest exodus state in the country, meaning people are leaving. Traditionally, younger people to find jobs elsewhere. Older adults might be going to warmer climates, but you'd be surprised to learn of the top 5 states that older adults leave New York for. Florida is in there, but the 3 others in the top 5 are Connecticut, Pennsylvania, and New Jersey. So it's not always going to Arizona, Louisiana, the southern warm states. It's going to places that might have better housing, more affordable housing, lower property taxes, et cetera. You can see for this region, the volunteers. These are small upstate counties, all rural, have almost 30,000 volunteers providing 16 million hours of service at an economic value of $446 million a year. So here's Essex County, very consistent, right? And you look at the demographics here, 72% of the economic activity is for the older population. You can look at the mortgage rates, housing. Why would we talk about that? Why do you care? Because if you own your own home, you are supporting Medicaid, the local schools, local property taxes, local businesses. You're spending your money, and it's really, really important. So again, I have this for every single county. We're updating it as we speak, as well as regionally. I'll turn it over to Becky.
Thanks, Greg, and hello, everyone. And I will put a selfish plug in. Prior to being with the association, I was a AAA director, and the data that Greg just referenced was so beneficial to use when I was either looking at grant funding opportunities or looking to speak with my county about additional revenue and funding. And it's always a nice way to make the case that the older population is so valuable, and why the services that I'm going to talk about through the local offices for the aging are so high yield, low cost, and more importantly, important in the overall health of the older population and caregivers. Again, the audience today is going to understand this wholeheartedly. We know that good health is not just made up from a diagnosis or a couple of your personal health behaviors. It's everything in your community, from transportation, housing, social participation, which was referenced in the last panel, to really talk about the impact of social isolation and loneliness on overall health, social inclusion, being able to civically participate and have gainful employment. And so, as Greg referenced, we have a huge volunteer block of the older population. We also have a lot of older people that are continuing in the workforce, which is a wonderful thing for overall health. Communication and information, community support and health services, and outdoor spaces and buildings. So all of these together were really the focus of having age-friendly communities. We're doing a lot of work with age-friendly health systems, because we know that health is made up of a holistic picture, which is all inclusive of what is included in age-friendly communities. Next slide. So again, when you talk about what determines health, it's really about different factors of risk of premature death that we wanted to focus on, because that's what our network does so well. So if you look at this chart, social and environmental factors, about 20%, individuals' behaviors, about 40%, genetics are only 30%, and then healthcare specifically is only 10%. So when you talk about really driving overall population health and healthcare spending, we know that the spend predominantly goes to the health system, but everything all of you do through community-based organizations and through our AAA network are really going to impact all of those drivers of those health outcomes. Next slide. I wanted to dive in a little bit for those that aren't completely familiar with what your Office for the Aging does locally. So as Greg mentioned, we have 59 offices for the aging throughout the state. Most are predominantly based within county government. We have a handful of not-for-profits, and we have 2 Native American Indian tribes who have their own independent office for the aging that works in conjunction with the others. And regardless of where you are in the state, you're going to see our core home and community-based services that are provided across the state. And then each AAA sometimes has localized programs. A lot of people only know our network for our home delivered meal program. We do run the largest nutrition program in the country, which is something we're really proud of, but that's just one small part of the work that we do through the network. We also have our congregate meal program at almost 800 older adult centers throughout the state. We have registered dietitians that provide nutrition counseling and education, which is super important to overall health in the older population. We have robust senior center programs, whether those be tech-based services or exercise programs. We have 41 of the highest level evidence-based health promotion and wellness activities, such as chronic disease self-management, falls prevention, diabetes self-management, and a whole host of others. Every AAA has volunteer opportunities, whether that be delivering a home delivered meal or being certified for health insurance counseling. We provide really robust caregiver supports. I'm going to talk about this a little bit further down the road, but I'm sure most of you on this call, not only are you professional caregivers in some way, shape, or form, but over half of you are also personal caregivers in your day-to-day life, either caring for an older relative or a younger child. We call those double duty caregivers. It's really important that we're able to support them. We do offer home modifications and repairs, such as installing grab bars in bathrooms or wheelchair ramps. We do a ton of work on elder abuse prevention and mitigation. We work really closely with Adult Protective Services throughout the state of New York, as we do see elder abuse really on the rise, specific on financial exploitation. So it's something we're laser focused on. We also run the New York Connects program, which is really a program that you can contact with any issue birth to death, whether you're looking for early intervention services for a child, all the way up to you need assistance in placing a loved one in a skilled nursing facility. You're going to get that objective information through your local office for the aging. One of the most important programs that we run as far as health outcomes, which was actually surprising to me, and I'll talk about one of the pilots that we ran in Western New York, is the fact that health insurance information and counseling was one of the biggest drivers for healthcare costs. Any of you that have tried to look at or work within Medicare plans, there are tons of plans that are very complicated. The wonderful thing about Offices for the Aging is we're not selling a product. We are mandated by law to be state certified, and we're giving objective information to the participant on the best plan for them, versus potentially having an older person approached by a commissioned sales representative trying to get someone into a plan. We also provide personal care level 1 and 2 for non-Medicaid eligible individuals. So we serve individuals that are higher income than Medicaid benchmarks, but they can't afford to privately pay for those services. And we use the same licensed home care provider network as the Medicaid system. We also provide very robust case management services. All of our case managers are state certified through Boston University of Social Work. Which is something that Greg instituted a couple years back. We're the first state in the nation to do that, to make sure our case managers had the same skill set regardless of where they resided in the state. We also pay for services such as personal emergency response systems and assistive devices. We do subsidize social adult day programs. Transportation, again, when we were talking about rural health, transportation to medical appointments, dialysis, chemotherapy, or to a specialty care is extremely difficult if someone loses their license or is no longer able to drive. Counties have wonderful transportation programs to assist those individuals, along with the long-term care ombudsman program. And we do a ton of work on combating social isolation and loneliness, which we'll talk about a little bit further. And I'm glad it was raised in the last panel as being a health driver. When you look at our customers, I think this is something that's really telling about the acuity of the people that are being served through your local Office for the Aging. We are serving high-risk, high-cost individuals, those with chronic conditions that have functional needs. And when you look really at the number of Medicare spenders, you see that those chronic conditions and functional limitations are accounting for 53% of the total spending, which is almost $400 billion annually. So again, those people with chronic conditions that aren't managed, that aren't supported, are more likely to use the emergency department or end up in a hospital inpatient setting. But we know when we look at our client base and what CMS has identified is home delivered meals, personal care services, transportation, are all the drivers that can really make change on behalf of those individuals. Just to run through this really quickly, you can see this is our clients that actually received services from 22 to 23 by county. And again, any and all of this data, if you're doing any public health needs surveys, assessments, want additional data, I think this is really an incredible tool to be able to say, we know this is our number of individuals with fall risk factors indicated, who have had a fall, who's at fall risk. We're using this information to actually talk to Medicare Advantage plans and MLTCs about how falls prevention programs or enrolling in some of our exercise programs can really move the mark on our fall risk indicators. And again, this is data that's readily available from Greg in the state to make the use case in your own community on either working with your local AAA or really targeting specific programs. I wanted to talk a little bit about some really innovative pilot programs, and through Greg's leadership at the state and us at the association, we've actually piloted well over 20 tech-based platforms or innovative services to support the older population. I wanted to highlight for this group A few that I felt were really in tune with the rural health theme. We're actually running one called the Everhome Columbia Pilot Project in Columbia County with some funding that was made available from the sale of an adult home, which was then endowed to start this project. And it's really amazing. It's using technology and care coordination in an integrated manner to change overall health. So when I say integration, is we all know that a tech solution is only a tech solution. You have to embed it within some sort of case management or care coordination platform to really get the best use case scenario. And what the pilot project has done, it has taken those high risk customers. It has employed technology into the home, including remote patient monitoring, with a caregiver support linkage through a 17-inch touchscreen tablet that's very user friendly. And it's really focused on a couple things: making sure people are able to remain safe in their home, and that an individual is not having to utilize the emergency department or a hospital system for something that can be managed at home. So a couple of the really unique features of the Columbia Pilot Project is they do use bed sensors, cameras in the home, 24/7 monitoring, but it also uses artificial intelligence to then alert caregivers to potential issues that may arise. And an example of that would be if your mom normally gets up to use the bathroom once per night, and that's her kind of standard. If the technology notices that she's up 3 or 4 times a night for 2 nights in a row, you're going to get an alert as a caregiver. This could potentially be a urinary tract infection. So it's a way to really track behaviors, see patterns, and then use intelligence to then make educated diagnoses that may affect the clinical outcome. And the beautiful thing that it pairs together with that technology is then you have 24/7 access in real time through the tablet to receive a telehealth visit. What they've done with the telehealth visit is if the physician on the other end of that phone, and they're all MDs at that level that are treating, if the physician feels like the issue may rise to a higher level of care, they actually have a paramedicine program where a paramedic will go to the home and act as the hands for the physician through the telehealth platform for diagnosis. Includes medication management, et cetera, and 24/7 availability of a caregiver, say they lived in Arizona, to communicate in real time with their loved one and with the care team. Next slide. Another amazing project that was done through BIP years ago, which was the Balancing Incentive Payment Program, which was very similar to a waiver that we're going through currently in the state of New York, was done in Erie County, where they brought the New York Connects program that I referenced to the hospital into a skilled nursing facility to assist with care transitions. We know the biggest gap in service and the highest risk for an individual is when they come out of either an acute care setting or a skilled nursing facility, because there are so many things that can really go wrong through that juncture. What our New York Connect staff did is they complemented discharge planning efforts by providing extra resources and bridge funding with the individual and family. They were able to use the facility-based care team and in-home services in conjunction with one another, making sure that an individual was connected to any and all community resources, and then made sure that they were monitored for the first month at home. And more importantly, and all of you know this, if there is not a warm handoff between service providers, there are huge gaps in care. And so this assured that there was a warm handoff, whether that client transitioned to an MLTC plan, to a waiver plan, or to a PACE program, so that the provider receiving that referral really had a holistic look at the individual. And you can see, because we did an analysis of this, the money that was saved for every dollar invested into this pilot showed a massive return on investment. Lastly, and I'm glad Greg gave Anne-Marie Cook a shout out. She is an amazing partner with us and has run the Community Care Connections program in Monroe County. Very similar. It integrates community-based aging services through primary care physicians' offices. All of you know this, whether you're a provider or a patient. Provider times are very, very limited when you're in that physician appointment. And there are a lot of things outside of just managing your chronic conditions that are going to affect your overall healthcare. And so again, this integrated community-based aging services through the physician office, they were able to connect with the evidence-based programs that I spoke about, home modifications, minor home repairs. And you can see, based on this data, hospitalizations were reduced by 50% for the first 90 days, 65% over 180 days. So this just wasn't a one and done. This had long-standing implication. It decreased emergency department visits by 62% in the first 90 days and 72% over 180 days. So again, this was a win, not only for that member of the community that does not want to have to bounce between those systems, but all of you know this, your HEDIS measures and the scores you receive for quality are really connected to how many times your patient is returning to an emergency department or inpatient setting. And the return on investment was $4.58 for every $1 invested, to the tune of $2.8 million. And thankfully, because of the efficacy of this program, it has been continued through lifespan of Greater Rochester, and it's something we want to see across the rest of the state because we know it works. Again, I'm going to go through this quickly. Self-help active services. This was done in Queens, so not a rural part of the state, but also you can see that, if you provide benefit and entitlement assistance, wellness programs, health screenings, care transitions, referring to partner agencies, all of these things in conjunction with one another are going to drive down the hospitalizations, the ED visits. And what was really telling about this model is they had a 76% reduction in the emergency department for COPD and CHF and pneumonia, which normally would drive people directly back to a facility-based settings. You can see that if a customer was involved in the self-help pilot, what their healthcare costs were for the hospital versus a Medicaid customer that did not receive those wraparound services. So again, this is the cost benefit on why it's so important to partner. Just to throw in a little bit of data, because we like to use data as far as what we do for legislative policy and advocacy. So back in 2018, we looked at our waiting list. If you work with your local office for the aging, you might be aware that many times, just based on the funding issues, we do have to waitlist individuals for our core services. And we wanted to know what happened to people that were waiting for our services. I'll tell you, our average client across the state is an 83-year-old low-income female who lives alone, has 4 or more chronic conditions, and needs help with bathing, toileting, dressing. So we know that they're very high need. The 2,200 people that we looked at on our own waiting list, 10% went directly to a nursing home. So we impoverished them to Medicaid instantly, to the tune of $140,000 to $150,000 per year. 7% went to MLTCs. They had a higher rate of hospitalizations and emergency department visits, a higher rate of death. And so what we did is, we know that that customer that I just referenced, we served them on average statewide for 6.5 years for less than $10,000 per year per client, versus that $140,000 to $150,000 in a skilled nursing facility. So just by addressing our waiting list, we were able to get a significant investment over the course of the past 5 years to actually meet the unmet need. And what is wonderful about the unmet need for the localities is that our funding traditionally goes through a funding formulary, where about 43% of the allocation would go to the New York City area and the rest would be dispersed across the rest of the state. Our unmet need funding went based on need. So in counties that had a very high need that they couldn't meet, they actually got much more in their allocations than they would have received if it went through the standardized funding formulary, which is really beneficial to those hard to serve areas. Lastly, just wanted to provide a quick update, because this is a hot topic under the current 1115 waiver that is being considered. We have historically had a very difficult time integrating our community-based care with payment models. As I referenced, a lot of the counties are county-based within county government. County governments are very risk-averse when it comes to contracting for healthcare items. And we are truly the drivers of social determinant of health interventions, just based on the service infrastructure that we have. So what we've done here at the Association on Aging is we were aware of this information. We were aware that we actually sit in a space where we could help those counties actually integrate with whoever the heroes are through the next 1115 waiver for the services that we provide, because we don't receive enough funding to serve the general population. So we've actually created a sister 501c3 not-for-profit organization who has now instituted an independent practice association called the Healthy Aging IPA. And we will be in that contracting mode on behalf of the AAAs for those services that they provide to those high-risk customers.
Awesome. Thanks, Becky. And I just want to kind of summarize, what's been new verbiage wise is social determinants of health, value-based payments, right? Things that we've been doing for over 50 years. Now you saw like the fall risk data, that's just individuals on our caseload. And there's over 80,000 without New York City. We know what chronic conditions people have: COPD, hypertension, et cetera. Carol talked earlier about, you know, vision and hearing impairments and their impact on dementia, loneliness, and isolation. We have all of those data sets because of the comprehensive assessment. We assess for anxiety, depression, alcohol, substance abuse, social isolation. We added a tech check in 2021 because a lot of the solutions that we're implementing coincide with the traditional ways we do work. Allows us to, again, if you identify somebody who's socially isolated, for example, we can connect them to some of those resources. If we assess somebody that winds up being a veteran or a spouse to a veteran, we can connect them with the Department of Veterans Services. Right now, 440,000 or 70% of the state's veterans are over the age of 60, and we have 25,000 on our caseload. So our network works in a way where we have to have statewide and local partnerships in order to leverage the expertise of others. If somebody has a diagnosed mental health issue or depression, that we can do that warm handoff that Becky talked about. And that's kind of the beauty of having the Offices for the Aging as part of county government, because they already have the infrastructure to work with public health, local transportation, housing, and all those other departments. So as I mentioned, we did our first ever statewide needs assessment survey back in the spring of 2023. I'm going to show you what some of the elements are, but what's really important about this is we have county by county data now that we just did a press release on May 1st that we released the county data. So I'm going to kind of show you briefly what's in it, but I know the Monroe County area has been in on the age-friendly work for a number of years. And what the needs assessment survey really did was look at 73 elements of age-friendly communities. I show you this because the link at the bottom, or if you just go to our main page, it's the first thing you're going to see. We'll actually have your county by county data in it. So of the 27,000 responses, we had responses from people from 60 to 110, from incomes of 15,000 to well over 250,000. And of the 27,000, about 33% were from hard to reach cultural and ethnic communities. So that, and it matched the diversity of the state. So we're really proud of this survey and the data that it collects. This is these are the areas that it asked on. And in summary, it's what do I think about myself, my future, my community, and my place to live as a place to live and retire? Would I recommend to somebody else that I'm gonna live here? How's housing, mobility, land use, employment, finances, so on and so forth. But this is kind of what the data looks like. And each of these reports, and I don't want to scare you away, I just want to let you know, because some of you are researchers who would be really interested in this. Every report is about 168 pages. This is just a summary document we put together. But the reason I want to really focus on overall health is because let's go back to the ageism, right? And the perception that older adults in mass are not healthy, they're frail, they have Alzheimer's disease, whatever the stereotype is. 72 to 75% based on our survey, which is consistent with data we've had for decades, consider themselves to be in excellent or overall good health, and over 82% overall good mental health and well-being. That's really important because there's a lot of programs and services that the community offers both within the Office for Aging and outside of the Office for Aging that can help maintain this status. And that's what we want to do. We want to keep these people in our communities and in our state, continuing to work if they want to, volunteer if they want to, stay socially engaged, et cetera, and keep their economic, social, and intellectual capital in our communities. It's that 25% that, as people that work to care for somebody, regardless of your setting, that we really have to focus on. And that is where these integrated community-based care models fit in. So let's just do the broad-based math, okay? We have 111,000 nursing home beds in New York State with a 97,000 capacity census right now. We have 4.84 million people over the age of 60. the name of the game in the future, in the present, and in the past has always been the community. Go back to the slide that Becky talked about. 60 to 70% of all healthcare costs have nothing to do with a healthcare diagnosis, has to do with personal behaviors and choices and how we grew up and how we grow older, poverty, clean air, so on and so forth. So the whole idea of the master plan, age-friendly work, smart growth, livable communities, transit-oriented development, whatever it is you want to talk about, really talks about how the community can rally around itself to rebuild itself to support people from birth to death. So it looks at overall community, housing, what people think, again, their perceptions, transportation and ease of travel, economic opportunities, engagement and recreation, concerns about their daily activities, both present and future, availability of resources, services and care, social isolation, crime and social inclusion, caregiving, and those are the kind of the elements that are in here. Their experiences, hospitalizations, and long-term care. And when you look at these, you see how high the numbers are of people that have not had those experiences. So we got to get out from underneath the global thought that older adults are frail and old and need help and are expensive and are takers, and recognize that it's a small subset and we can serve both at the same time. And that's really the goal. And as I said, if you go to our webpage, aging.ny.gov, you will have a county by county breakdown of this exact data for your county. So we're going to go into some of the new initiatives. Becky, we literally have like 4 or 5 minutes left. So we're going to zip through these very quickly. And these really help to bolster what Carol had talked about right before we went on. She talked about the value of pets. There are things, regardless of our age, that make us tick. News, sports, pets, arts and culture, right? You don't just turn that off at a certain age, and you can pick up new things as you get older. So we started our animatronic pet project back in 2018. We did the first study and after 1 year of putting these pets out into the community, they were shown to reduce loneliness, isolation, depression, and pain by 75%. We have now put out over 31,000 pets to your area as well as others, and our model has been replicated in over 36 states at the moment. Carol also talked about playing. She was talking about playing video games, which is great, but Ageless Innovation also developed a partnership with Hasbro to take some of their most iconic games and make them intergenerational. Things like Trivial Pursuit, The Game of Life, Scrabble, and a couple of card games. Since September of 2023, we've done 116 reach out and play events to get people together to play, as well as bringing high school students in on an intergenerational basis to be able to interact with older adults. And we're going to continue to do that. Those are games I can provide to any of you guys if you want to help us in organizing some of these events. To see it in action is incredible, and I don't have time to go into it all. Get set up. Carol talked about lifelong learning and engagement. This is free for anybody over 50 in the state of New York. So please advertise, 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 advertise. Anybody over 50 can go in and have access to over 4,500 lifelong learning, health and wellness, and other types of classes. What's great about Get Set Up is the first thing it does is addresses the digital divide, meaning it's going to teach the 50-plus person how to use the device that they're using, an iPhone, a desktop, an iPad. All the classes and courses are taught by people 50 and over. That is huge. Peer-led classes. And I'll tell you why. I got a 20-year-old daughter, and when I ask her to teach me about something, she gets extraordinarily frustrated at my stupidity, and probably should. So it's much nicer to have somebody that understands me as a 55-year-old, and I'm not technically stupid, but I'm not my 20-year-old daughter either. The other thing that's great about this is if you have a skill and you're over 50, you can sign on to teach a class and actually get paid for it. So there's an economic opportunity. Becky talked about transportation. That has been an issue for since cars have been around and since the institution of suburbia, which started in Melville, New York after World War II. We've put housing over here and everything else over there. And if you lose your ability to drive, you're screwed, frankly. 95% of the state's geography has no public transportation. It assumes you can afford it, you know how to use it, and you can physically use it. So we partnered with GoGo Grandparent, which is a specialized rideshare program that teaches the drivers and the unique needs of older adults to not be the solution, but another tool in the toolbox. And I want to let you guys know that the state has organized a rural transportation task force that I sit on that has begun meeting to really address this issue. If you don't have access to transportation, you're completely isolated or reliant on somebody else. And to Becky's point, you know, I provided her a grant for 2 straight years because in the county that she ran in Franklin, there was no dialysis in the entire county. So I think Becky, you either had to go to Plattsburgh or Burlington to get dialysis, and there was no funding for that. So those are the types of problems we're trying to solve. You're up, Becky.
So really briefly, and again, I just want to highlight the fact that all of these links are live because I know we're going to go through them really, really quickly, but we're trying to spread the word and get this out into the community as much as possible. We have a nationally recognized partnership with an organization called Archangels, which does the Caregiver Intensity Index. Again, caregiving is a huge issue, not only in the state of New York, but also on a national level. And we know that caregivers are suffering from mental health issues, alcohol and substance abuse, and a whole host of other issues related to losing time at work, having issues with an employer. The Caregiver Intensity Index takes less than 2 minutes. It instantly gives whoever has taken it. And again, take the time to click on the link and try it out. It will go through, it will tell you if you're in the green, yellow, or the red. It's self-explanatory. If you're in the green, you're doing well. Yellow, might want to pay attention to things. If you're in the red, you really need to make some changes or get some supports. It instantly will give you the top drivers of your caregiver intensity and your top buffers. It will also then connect you directly with our New York Connects online resource directory, so you can access services. And it also connects you with TruAlta, which is the next bullet point. TruAlta is an evidence-based online caregiver support platform. It is amazing. I would share this with every individual that I came into contact with. It gives you bite-sized information on your caregiving journey. So instead of looking up caregiver supports and having to sift through dementia or mobility impairments, it literally comes up with a comprehensive plan just for you in your caregiving journey. And then you can either download it in print, listen to a podcast, watch a video. They also have a very robust online support group, which you can either participate in by sharing your camera and your information, or more importantly, they have a completely anonymous online platform that has blown up over the course of the past year, where people can literally get on and communicate with one another in a safe zone. They can talk about their journey without being identified. So again, please share this far and wide. We have 19 counties in the state of New York that's currently involved with a virtual senior center platform, which has literally allowed senior centers to become 24/7 virtual programs. One of the coolest features that I find, and sleep was mentioned earlier, if you're an insomniac and you're up at 2 a.m, you can log into your virtual senior center and get supports. Intuition Robotics, again, we're going very quickly through this. This is an amazing artificial intelligence platform that we have seen over 95% reduction in social isolation, loneliness, and depression through deployment of the units. It looks kind of like the Pixar lamp with a touchscreen tablet. It will follow you around your house visually, but more importantly, it learns with you. So your LEQ unit will get to know your behaviors, your likes, your dislikes, your habits, and actually engages you. Instead of like an Alexa where you have to say, hey, Alexa, LEQ, when you get up in the morning and it senses you moved, will say, good morning, Becky, how did you sleep last night? It does medication reminders. It will prompt you to drink water. It will bring you on virtual tours. If you want to have a cup of coffee at noon and go to Venice, it will actually bring you through that. We've seen an amazing, amazing outpouring from the people that have gotten these units, that it has changed their lives and has become like a family member.
All right, I'm gonna, we have 1 minute before, because we want to give you time for questions. So I'm gonna just show you these. We'll send you the slide deck. If you guys ever want a deeper dive on any of these, happy to. What we're doing, nobody's doing, not only in New York State, but across the country and the world. And we're often asked to speak everywhere about, we have over 20 public-private partnerships. So Better Age, Blooming Health is in the SMS text message voicemail space, doing a lot with Anne-Marie Cook to pilot Bill Payer, Fraud Finder, EverSafe to combat and prevent elder abuse. Derota's Friendly Visitor Program created a video series. We created a bunch of video tutorials to allow individuals to apply for 14 different New York State benefits from the privacy of their own home in a comfortable way to make it as easy as possible to get it 99.9% done. And then we are launching all of these additional things that support older adults with Alzheimer's, their caregivers, evidence-based strength and training, memory lane TV. We talked a little bit, or Carol did, about travel. Discover Live. We have in 51 senior centers. It allows you to travel to 200 countries once a week, and so much more. The appendix, I want to point out, because we just don't do these things to do these things. All of our outcomes data are here, and you can take a look at it. So I'm going to stop there for questions. The outcomes are really important because the bottom line is this. I can't subsidize every older adult in New York State. The data is critically important, so we have free things. You can advertise those, use them as much as you want. The things that we're testing, we have outcomes measures. We will send this to you. You can take a look at them. There are many older adults that have resources that can buy this. There are many people like me that can afford this on behalf of my parents. There are mainstream insurance plans, Medicare Advantage, MLTCs, 1115 waivers, even your own organizations that can afford to do these things. And when you see the outcomes, you're going to be blown away. For either little or no money, these are low budget, high yield impacts that help wrap around what we're all trying to do, that bring together not just medication reminders, and telehealth, but the things that really matter to us, the social isolation, the connectedness, the lifelong learning, the exercise programs, the relaxation, hydration, and so on and so forth. So we're going to stop right there. And sorry we talked so fast. Happy to get all of this to you. And if you ever want a deeper dive, we would love to do that for you. And I was just joined by my daughter, and she's clapping too.
Your daughter's clapping, the audience is clapping, lots of high fives and clapping and hearts coming out of the reactions. Greg and Becky, thank you so much for being co-presenters today. And we do have several questions, so I appreciate you. There we go. I appreciate you leaving time for that. So the first question is in regard to the expression that you talked about called silver tsunami, Greg. And one of the audience members is thinking out loud, what is a positive, catchy phrase we could all use instead of silver tsunami? I would propose, if you have any suggestions, I'd love to hear them, but also go ahead and pop it into the chat if you think you've got a suggestion as well.
Yeah, I think that, I understand the reason behind the word. Words matter, and they perpetuate a negative stereotype. So you'd never heard Becky or I say senior citizen, or elderly. Not because I made those words bad. They elicit a negative response. I mean, you'd be stunned to learn that statutorily in New York State, 60 plus is elderly, right? I've been trying to scrub that from the statute for 17 years. We just simply say older adult, older New Yorker, older individual. But we have to be really cognizant of that particular word, and there's others. Silver tsunami is negative. And like I said, what good ever came from a tsunami? Just devastation and destruction. And that's the message that leads people to believe, because we've been conditioned societally to think negatively about the population.
Thank you for that. I'm going to go ahead and move on to the next question. This is a comment. Thank you, Greg, for sharing these facts about older adults and the impacts they bring to our community. So our next question is, I run a medication assistance program, and I really wish that Medicare eligible patients would make appointments with Office of Aging to have their Medicare plans looked at. I get so many referrals for patients that have signed up for plans on their own. If they had gone to the Office for Aging, they would have been eligible for more assistance, such as MSP or LIS.
Yep. Well, thank you. And everybody should be doing that. So, you know, we served 275,000 people in our high cap program last year, put $145 million into people's pockets. We should not be buying things from, and no offense, I was a Magnum PI guy, Tom Selleck, or famous football players like Joe Namath, who I love too. You know, we ran PSAs saying when you get bombarded in October, you know,
Yep.
call us, right? And we literally put things out saying, don't call them, call us. The MSP program's critical. We could put $600 a month back in people's Social Security checks. And then if you add SNAP to that, somebody on a $25,000 income can have their income raised to $35,000 just on those two programs. You're absolutely right. And I hope that Anne Marie has done a presentation for you guys on her CCC program. But one of the #1 reducers of ED visits and preventable hospital readmissions is high cap counseling. And our entire budget's like $3 million. So for our AAAs that are here today, they do yeoman's job in their high cap program, but we could easily beef that up, you know, do some marketing to kind of counter the industry marketing that Becky was talking about. And like I said, or she said, you know, when you call somebody like that, you're getting their product, whether it's right for you or not. When you call us, we provide objectivity and choice, and then it's up to the consumer to decide.
I think the other piece to underline with that, Greg, is there are a lot of older people that have a connotation that they don't want to apply for any type of public assistance benefits. They don't want to go to their local Department of Social Services. When you go to your local office for the aging, we're going to screen you for any and all services. So if someone comes in to look at a Medicare plan, we're going to see, are they eligible for HEAP? Do they have the STAR exemption for their home if they own it? Can we get them SNAP? Can we get them on the MSP program? And so a lot of people walk in not knowing what they're going to walk out with, and they walk out with, you know, thousands of dollars in their pocket, and they no longer have to choose between buying medications or buying food.
Yeah, and another, you know, just I'm glad you raised that, Becky. People don't know what they don't know until they need to know it, right? And there are so many things out there, both within our agencies and others, that people may be eligible for, but they don't know. And here's two great examples just that we will all understand. You don't need to know about the STAR property tax rebate until you own your own home. You don't need to know about TAP and Pell until you send your kids to college. There are so many of those types of things. Veterans are eligible for 115 federal, state, and local benefits that they're not aware of. And so I think one of the things we want to get out of the master plan for aging is a consolidated way that kind of lists all of those things, because they're embedded in so many different, not only state agencies, but then counties go further. Like New York City has DRE and SCRE for property tax. So it's all over the place. And again, you don't know what you don't know.
And I will just put one more plug in because of who the audience is. So through NYSOFA, over the course of the past few years, we have done video tutorials where real live humans do applications on YouTube and describe every portion of that. So you can either use that to train your staff or provide to anyone you're working with, because they can literally sit down on YouTube and do a SNAP, Medicaid, HEAP. All of those applications are done through how-to videos, which are incredibly helpful to family and older individuals.
And that link was in the slide deck.
Thank you for those points. Appreciate that. I'm going to move on to our next question. There seems to be a big difference in what is offered from one OFA to another by county. Some have lots of services and some are barely there. In areas where there is not a very active OFA, what is the best way for them to contact someone?
Yeah, I mean that's true. So the services that you saw are actually required to be provided in every county, the ones that Becky went over. But there's a difference in funding, right? Because the way that we are required to send money out is by funding formula. So your 60%, 60 plus population percent as the whole, which is why the unmet need funding is so important, because we bypass that formula. But here's the bottom line, guys. I can't answer this. We have so many great OFAs and great directors, and all the ones that are on here are really great. But we've all worked in organizations where good leadership is good results and bad leadership is bad results. I don't hire the directors or the staff that's done at the county level. And it doesn't matter what organization you're with. We've all been through that. So I think the overwhelming majority of the OFAs do a tremendous job with the resources that they have. We're all dealing with workforce. A lot of the attention is on healthcare and long-term care. We're dealing with the same things in the not-for-profit sector or the county sector. So, you know, I'm hoping what the data provides and what we talked about is an opportunity to educate your counties and to work with other partners like those that are here on how to integrate those things, because the stuff that we do is a lot more inexpensive, and the scores and how you get whacked for not providing good care is a reason to partner with us.
And I will also say that regardless of where you are in the state or your relationship with your local office for the aging, all of the links that we provided to the audience today, those are statewide. And those are available to you without going through the local office for the aging. And then I would also offer, if anyone's interested in maybe having a new relationship with a local AAA, I'm more than willing to assist in having those conversations and getting people connected. To Greg's point, a lot of times, sometimes just sitting down with leadership can really change relationships moving forward, and I'm more than willing to assist with that.
Thank you both very much. I want to get to this last question before we take a break for lunch because it's a good one. They're all good questions. This one as well. If a senior adult with a developmental disability who lives alone or with family but uses DD services, are they eligible for older adult programs?
It depends on what they're receiving. So for our services, they are available to anybody 60 and over. There's only 2 programs that we offer that actually have criteria for participation: home delivered meals and our ISEP, our in-home program. We're going to make some modifications to that. So it would really be on a one-on-one basis. But the bottom line is, if you're 60 and over, you're eligible for our services. So we just have to see who's paying for what.
Just to clarify, I will say, because this has been raised in the past, if someone is currently enrolled in fee-for-service Medicaid or an MLTC and receiving home care, we would not cover them for home care. Because if it's covered, and if they're enrolled in DD services, they're obviously a Medicaid recipient. So we couldn't provide home care services, but we could provide all the other services that Greg and I had talked about.
And to follow up on that, 75% of individuals with IDDD don't touch any formal system. So, you know, they've been taken care of by their parents, who are probably in their 80s, 90s. Now they're, you know, moving into the 60 range. So, you know, we've been doing a lot of training and trying to do some additional work to address that gap that's been rising for some time.
Okay, I can't thank you both enough for being here. Greg Olsen, Rebecca Preve, thank you so much for taking the time to be with us today and talk about this very important information across New York State and with the Office for Aging. I believe that we did get to all of the questions. If we didn't, please know that we've captured them, and we will make sure that we can get those questions forwarded to Greg and Rebecca.
Can you just make sure that the slide deck goes out? Because I saw some questions where the links are in our slide deck. Anything with a blue link, guys, is free. Advertise the hell out of it, please.
Go ahead, sorry. Sorry, Greg, I didn't mean to cut you off. I just wanted to let you know that any slide presentations that were forwarded to Laura will be put in Box, and all of our audience have access to Box. So as long as you shared your slides with Laura, we can get them uploaded and share them with the audience. So good to know all those links are live and active and people can click on them. We appreciate that. We want to thank you again for being here. Hope you can stay on for more of our conference today, and hope you have a really great Friday and a nice rest of your weekend.
Thanks, everybody. Have a great weekend.
Guys.
Thank you.